And what I'd like to talk about today are the results of an analysis that we did on pediatric age patients that were seen by Doug and other members of the Johns Hopkins Transverse Myelitis group. The reason that we did this is we wanted to find out about what was known about transverse myelitis in children. Specifically, what are some of the predisposing factors that occur in these individuals? How do they present? And most importantly, what can we tell parents in terms of how these children do? You know, what are their functional outcomes and prognosis? And if you look at the published literature regarding pediatric transverse myelitis, very little is actually written about how kids do after they get transverse myelitis. One reason for that is that it's a very rare condition. And as Sandy said earlier, due to Doug Kerr's efforts, we now have enough information where we can start to look at some of these questions much more effectively. And this report is one of the fruits of that endeavor. What you see here are the published cases of pediatric transverse myelitis. And our report would make the fifth one. The other ones cover quite a bit of time span. The first one that was published, this one here, they collected cases from 1929 to 1952. The Dunn paper, 1966 to 1983. Knabush, 3-year period. De Fresnay, another 30-year period. So it took quite a bit of time to collect patients in the past, whereas the group that we're going to look at and talk about today was collected over about a 4-year period. So you could see that having a center specifically dedicated toward transverse myelitis has not only led to a larger number of cases that we could treat and give advice to the families for, but also collected the information over a short period of time so that we could start to look at treatment advances in that particular group. The objective of our analysis was to correlate clinical characteristics associated with the onset of acute transverse myelitis in children with functional outcomes at the time of follow-up. And what we chose to do was pick outcome measures that had been validated and are reliable, but also look at specific areas of function. And this has not been clearly looked at in previous case series in children. And we also used the diagnostic criteria and classification scheme that was developed by the Transverse Myelitis Consortium Working Group. And this is also a key factor because now that we have these criteria, we could start to compare like groups of children and not worry about could there be some individuals in this group that really didn't belong there. The measures that we used was chart analysis, clinical evaluation on those children that came to see us, and we chose 2 scales. One was the Hughes Functional Disability Scale, and the other one is the Functional Independence Measure, also known as the FIM, and the pediatric version is known as the WeeFim. This is what the Hughes scale looks like. It's basically a 6-point scale that really looks at how mobile or how ambulatory individuals are. And it goes from a score of 0 for normal, 1 minor symptoms, fully capable of manual work, 2 walking more than 30 feet without assistance, then walking more than 30 feet with assistance. Number 4 is wheelchair mobility. 5 and 6 are ventilation and death. This is what the WeeFim looks like. It's a more detailed measure. It actually has 18 items that looks at different degrees of function, and they measure essential daily skills in things like self-care, mobility, and in some cognitive domains. This was designed to document functional performance in children with either acquired or congenital disabilities. And in this particular scale, which is more complicated, each item is rated on a scale of 1 to 7. And this is sort of what one of the scoring sheets looks like for the WeeFim. And what I wanted to point out here is the scoring scale, where through an interview format, we ask families or the patients how much assistance they need for each one of these different tasks: eating, grooming, bathing, dressing, toileting, bladder management, bowel management. And you can see it goes through each of these different domains. So what we're going to talk about today, what I'd like to present, is some of the information that we gathered from giving these two functional outcomes scales to children who had transverse myelitis. The participants in this study were 47 patients with acute onset of TM less than 18 years of age. And 89% of the cases were monophasic idiopathic transverse myelitis. There are only two recurrent cases, but of course we are dealing with children here, so they may not have had their reoccurrence. 4 cases had disease-associated transverse myelitis, such as Devick's disease, lupus, or ADEM, and 1 case in the group that we looked at subsequently developed multiple sclerosis. Well, this is one of the first things that we noticed when we looked at the data. There were 2 peaks of age of onset. And usually when you read these case series about transverse myelitis, they'll say something like the mean age of onset was 8 years old. And as you could see, that might be the mean age, but most of the cases clustered either below 8 or above 8. An unusual aspect of the group of patients with transverse myelitis that we looked at was this large proportion of cases less than 3 years of age. There were 18 children with acute onset of 3 years of age. And what we think is that's probably a selection bias issue, because the families with children with transverse myelitis would actively seek us out and ask, what is the latest information that's available with regard to treatment and, of course, rehabilitation. In our case series, about 38% of the cases were under the age of 3, versus about 10% for the other case series that were reported. The other possibility is that there's something that's changing with respect to those antecedent factors that trigger the immune system to develop an inflammatory reaction against the spinal cord. And could this be an indication that for some reason in either infections or the issue of immunizations has come up, what parents are feeding their children perhaps? Could there be some reason for why we may be seeing more children at the younger age group develop TM? And that's a question that we really don't know the answer to yet. So what we did is we wanted to find out, well, let's just take a look and what were the retrospectively identified potential antecedents? What factors were associated with the onset of TM in this pediatric group? So a febrile illness within 30 days of onset was reported in about 47%. A confirmed immunization or allergy shot was seen in about 28%, and there was a history of trauma in about 13% of children. Now, of course, childhood febrile illness is very common in children. They're getting colds and fevers all the time. Immunizations, very common. There's all kinds of schedules now for immunizations. So we're not saying that these antecedent factors, we don't have the ability right now to say whether these antecedent factors specifically cause TM in these patients. We just know and have reported that these are the incidents of those factors in this group. We can talk, and we're going to talk about that in just a second some more. Oops. We looked at what were the acute symptoms in these children. 75%, as Doug mentioned, presented with complaints of pain. Sensory loss or numbness was very common in 91%. Bowel and bladder dysfunction, specifically urinary dysfunction, 85%, and weakness in 89% of the children that we saw. At the worst point of their illness, 89% of children were also either wheelchair-bound or bed-bound or required assisted ventilation. So we then looked at the children at the time of follow-up afterwards to see how many of these symptoms persisted and what their percentages were. and our median time of follow-up was 3.2 years after onset. And not surprisingly, there was quite a high incidence of persisting problems. In the three areas that we talk about, starting with sensory, 54% still complained of uncomfortable or irritating sensory findings, numbness, tingling, or pain. 75%, quite a big number, 3 out of 4, continued to complain of some kind of numbness. Bladder problems were present. About 50% required catheterization, and about 68% complained of urinary urgency. And in terms of the ability to walk 30 feet, 43% were unable to do that, 21% required a walker or other support, and about 1/3 were independent ambulators. Here's a graphic representation of what that looks like. And what you could see is here at the time of, and this is specifically for ambulation ability, acutely, the white bar here, just a very small percentage could walk without help at the time of acute injury, but at the time of follow-up, that increased to about 1/3 of the patients. The black bar is about the 89% that could not walk, that were non-ambulatory, and that decreased to by about 50%. So one of the things this suggests is that if you have a child who's non-ambulatory at the time of diagnosis, the family wants to know, well, what are my chances that my child will be able to walk either with a walker or a cane or independently? It looks like about half of those patients will develop that additional skill. This issue is very common in children with transverse myelitis. It's the issue of bladder management. What does it look like at the time of diagnosis? And what does it look like at the follow-up? And as you can see, at the time of a acute presentation, a very small number had no complaints of urinary dysfunction. And at the time of follow-up, that number increases to about, let's say, 20%. So the majority of patients at a mean time of about 3.2 years after diagnosis had either urgency and required catheterization, or required catheterization. And that breaks down to about 1/3 in each of those categories. So if the question that's posed to you at the time of acute presentation is, what are the chances that we're going to have some kind of urinary problem in follow-up, the answer, at least from this information, in this group that we looked at, is probably about 80%, divided about 30 and 20% between those categories. We took a look at the outcome measures, specifically the WeeFim or the FIM, if they were at the time of follow-up an adult, and we wanted to know which variables were associated with better outcomes. And these are the things that we found that were statistically related to a better outcome. An older time at the time of diagnosis seemed to correlate with a better outcome, suggesting that there might be something about that group of 18 children that we saw under 3 years of age that might be different from the older individuals. A shorter time to diagnosis seemed to be associated with a better outcome. Now, one thing that we really couldn't get a good handle on in terms of our data analysis was one form of treatment better than another form of treatment. That remains for future analyses, but there's something about looking at the individual, making the diagnosis right away, and then giving the appropriate therapy seems to be related to a better outcome. Lower sensory and anatomic levels of spinal injury associated with a better outcome. This was a new finding. This hasn't been reported before, that the absence of a type of abnormal finding or lesion on MRI, which is a T1 hypointensity signal. If that was not there, then those individuals did better than the individuals that had a hypodense or hypointensity T1 signal. And lack of white blood cells in the cerebral spinal fluid correlated with the better outcome. And that, again, makes sense based on what Dr. Kerr mentioned in the previous talk about white blood cells being a marker for inflammation. And also, this last one also makes sense, too. If you had fewer affected spinal cord segments, you tended to have a better outcome. This is how we put together the information on WeeFim and FIM at Followup. If you look at these 4 domains, self-care, sphincter, the ability to transfer between bed and wheelchair or a wheelchair to a commode, and the last one is your locomotion skills. How do individuals do there? And I think here the bars to look at would be the dark colored bars. That means independent function. And what this graph is telling us is pretty much, if you look at the criteria measured by the WeeFim and the FIM, that pretty much 50% or more individuals who, in this group that had idiopathic transverse myelitis, will be independent in the self-care, will be almost independent for sphincter control. Transfers, it's about 60%, 65%, and locomotion about 65% too. So in terms of your ability to perform the items on these scales, it's more likely than not, more than 50%, that you'll at least achieve an independent level of skill in these areas. I'd like to say a brief word about the spinal MRI findings. These have previously not been well described from the previous study, mostly because the duration of time that these cases were collected extended into the pre-MRI era, so the information just wasn't available. And the information that's been published doesn't really go into detail about the difference between T1 signal abnormalities or T2 abnormalities. What we found was that T1 hypointensity on spinal MRI was associated with worse scores on the Hughes score at follow-up and a trend toward worse scores for continence outcomes. So it gives us a marker early on that will help plan the rehabilitation care down the road. Another finding was that a lower level of lesion on the MRI was associated with a better outcome for both ADL and mobility skills. And fewer involved segments were associated with a better outcome for ADL and mobility scores. One of the conclusions that we drew from this information was that using our current MRI imaging techniques, that they appear to be sensitive to diagnosing acute transverse myelitis in children, in that 36 of 38 cases that we knew had MRI findings had abnormal signals attached to them. A couple of surprises when we looked at the information. One was that there was no correlation with worse outcome associated with rapid progression to maximum impairment in less than 1 day. And this is a finding that's been reported in other case series, that if you crash, and if all of a sudden within 24 hours you can't walk, or the common story we get in pediatrics is they went to bed, they had a cold for a couple of days, they went to bed, and in the morning they couldn't get out of bed, they couldn't walk. And the thought was, if that was the story, then they would have a more severe outcome. We didn't find that to be true in our group. And there was no worse outcome associated with antecedent illness, immunization, or trauma. So what that tells us is that if you have a history of one of those 3 things, illness, immunization, or trauma, it doesn't mean that you're going to have a worse outcome. It doesn't say anything, though, about whether those things were responsible for triggering the immune reaction. Another interesting finding was that the patient scores on the Hughes scale at the worst part of the illness in children were significantly correlated with functional outcome at follow-up in all 3 domains, both ADL skills, continence, and mobility. And so what that means is that we have a tool early on to classify perhaps how the kids are going to do later on when they're followed up. This is just something that I wanted to show to give you some idea about how this group of children that we followed at the Johns Hopkins Transverse Myelitis Center compares to the published literature. And the top part of this table just as a review of what I said earlier, if you look at the group of children that we saw, 47 cases, acutely about 91% complained of sensory loss or numbness. And in the chronic phase, that persists in 3/4 of those individuals. Loss of mobility was found in almost all of those children acutely, and in the chronic phase, about 64% still had loss of mobility, meaning that 36% did not. Urinary dysfunction was seen in most of our children acutely, 85%, and that dropped to about half of the individuals in the chronic phase. And if you look at what Knabush said in terms of what's the prognosis for children with transverse myelitis, he broke it down into 3 categories: good, fair, or poor. And the problem here is it's hard to define exactly what's meant by these descriptions. Gait essentially normal with mild urinary symptoms and minimal sensory loss, 44%. Fair, mild spasticity but independent ambulation, urgency and/or constipation, some sensory signs, 1/3. And then poor, unable to walk or severe gait disturbance, absence of sphincter control or sensory deficit. So previous studies have kind of tried to figure out try to categorize it into good, fair, or poor, but I suspect that what they're calling fair might be what we're calling significant urgency or a need for catheterization. So the conclusions that we can draw from this information, these are some conclusions that we drew from this information, was uncomfortable sensory sensations suggest that management of ongoing pain is an important part of long-term management in not just adults but also children with acute transverse myelitis. Another conclusion was that although a shorter time to diagnosis was associated with better outcome, this finding requires cautious interpretation because we're not quite sure what the relationship was between early treatment and subsequent skills. And the 2 areas that I think require additional work are both what are the results of the medical intervention on the effects of on the ultimate outcome, and what are the effects of rehabilitation interventions on the effective outcome? And we weren't able to analyze that in this group, but this is something that we're going to be looking at in the future. Okay, so thank you for your attention, and I'm happy to answer any questions that you might have.